Well, again, thank you for having me. Let me just jump in and talk a little bit about where I work. Yes, I am an engineer by training, but I've spent my entire career working inside a hospital setting, a quaternary center at the University Health Network in Toronto. And I am sitting right now a few floors above emergency on the fourth floor of the R. Fraser Elliott building, and as do my staff. And so I have clinical responsibilities for the health technologies of UHN as well as my research interests and what I will be talking about today in the context of the human factors work that we're doing. And I'll talk a little bit about them as well, the human factors team at UHN. So just a little bit about UHN. We're a large quaternary center. We do about 1.2 million outpatient visits. We have about 23,000 employees, many of them just strictly in the research area. We spend about $3 billion a year, and as much as $600 million a year on research activities. And sort of the scope of what I'm responsible for is a lot of the technology, and we have like a $500 million worth of technology in our inventory, and we spend about 30 to 50 million dollars a year on new technology every year. And I think one of the things I'm proudest about internationally is like we're ranked amongst the top hospitals in the world. But also, I mean, we're one of the top rated public hospitals, and I think that's really important as a Canadian on the public support of healthcare. And the team that I founded about 20 years ago is called Healthcare Human Factors, and they are a hospital-based center with usability facilities and individuals who have backgrounds in clinical engineering and human factors engineering and cognitive science, in formal design, and I mean, they're my secret weapon, quite honestly. They spend their entire time every day criticizing what they see in healthcare from a human performance, human cognition perspective, and how the design of systems in healthcare are often harmful to patients and the provider. And this is something that was born out of originally the aviation industry, and many other industries adopted it. And unfortunately, healthcare was one of the last ones to adopt human factors principles. But you're seeing it now used, especially in the design of technology, and in particular, it's a requirement of medical devices. We're seeing it being used more pervasively throughout the healthcare sector. As big as this team is of 30 people, we are just scratching the surface of what's needed in terms of human factors in healthcare. And the types of things they work on are quite varied. They work on workflows. They work on the design of facilities. They even design children's applications that help a child manage chronic pain. So this is something called I Can Cope, which they designed for the Hospital for Sick Children across the street. And they worked with Elekta on this MRI guided radiation therapy machine. So this was a new novel way of delivering radiation therapy using MRI imaging instead of CT imaging. And 10 of our staff worked on this for multiple years in multiple locations around the world in helping bring this product to market. And interestingly, the human factors techniques used were the same for this very sophisticated piece of technology and the development of that application for children. It's the same techniques, the same lens in terms of optimizing the user experience and minimizing the effect of the technology on the person, the negative aspects of the use of technology. So, so in the safety realm, this is really there's like sort of twofold. There is user experience, having good experience, but obviously human factors is very critical on the safety side. And I think last year around this time there were a lot of notable aviation disasters. One in Toronto where you can see that this Delta flight flipped over, and then quite tragically at the in Washington D.C. there was a collision between a military helicopter and a flight, commercial air flight. And these are very high profile. They were in the news for many weeks and months, and there was a lot of concern about aviation safety's record. But compared to what we see in healthcare, it's really a drop in the bucket. Like healthcare, the number of incidents are much higher than in any other safety critical industry. So just as a point on that, the fatality risk in aviation is about 0.06 per million flights, meaning an individual would need to fly every day for about 16,000 years to experience a fatal accident. That's how safe it is. And I think most of you know that healthcare is, in fact, not anywhere near that safe. The classic study back in 1999 showed that at least 98,000 Americans die each year from preventable adverse events. And that is to err as human. And there was a Canadian study that was done subsequent to that that was published in about 2002 and 2003. And the number back then was about 21,000 Canadians die of preventable harm every year. And the numbers and how you're counting them are often reframed, but we are actually making very little progress on safety in healthcare, even more than 20 years after these studies were published. And I think there's lots to be learned from obviously aviation as a safety critical industry. The energy sector has actually a very good safety record as a safety critical industry. And what I defined as safety critical industries are these: nuclear power is a safety critical industry, aviation, energy, the military is a safety critical industry, and you might imagine like why that might be the case. Human factors is used in the military all the time. If you think about those huge aircraft carriers, they are mostly manned by 18-year-old young men. And so that's, as a demographic, that's not a demographic that you typically associate with safety and skills and so on. The 18-year-old males aren't known for being cautious and being thoughtful. Yet there's very few incidents involved in adverse events in the military as a result of how well designed those aircraft carriers are. And the other interesting safety critical industry listed here is finance. And finance was kind of added to the list after the 0809 financial crisis that gripped the North America and other sectors, other jurisdictions. And now we consider, the protection of our financial systems as being critical. And you'll notice that I didn't really put healthcare on this because we do not behave as a safety critical industry when we compare the organization and the governance of these industries compared to healthcare. I'm going to jump in and talk specifically about sort of the most prominent aspects is aviation, nuclear compared to healthcare. And what I see is the gap is that in these safety critical industries, there are lots of regulated aspects to these safety critical industries and lots of controls in ensuring that this happens. Sorry, I just lost it here. Let me just go back here. And in healthcare, we have ad hoc controls and we're much more heterogeneous. And so there's little to suggest that there's the same rigor or approach towards the systemic management system for quality and safety in healthcare delivery when you compare aviation to healthcare. And in the nuclear energy industry, there's also a lot more change control and change control processes that need to be assessed for impact on worker fatigue and safety. So you can't just ad hoc make changes in a nuclear power plant. They need to be assessed for impact on the worker and on the overall safety. And when we compare this to healthcare, here's a paper by Don Berwick's team down in the US. And, they sort of described healthcare as a cottage industry. And because of the lack of governance and the lack of the ability to have a consistent approach to the delivery of care. So what they said very explicitly is that the healthcare system is a cottage industry of non-integrated, dedicated artisans who eschew standardization. Services are very highly variable for performances, largely unmeasured. Care is customized to individual patients, and standardized processes are regarded skeptically. Autonomy is hardwired into the system because most physicians practice in small groups with limited oversight or coordination. Even those who work in larger groups include academic medical centers, create individualized care plans that cannot be integrated with care in out-of-network facilities, and they cannot treat or track patients over space and time. So that lack of consistency and I experience here at UHN, if you go from floor to floor, if you go to clinic to clinic, you can see the level of variability in how care is delivered, despite the fact that we're under the same banner as UHN. And one of our CEOs some time ago, when he was first visited all the clinics, he, likened us to a farmer's market. Like everybody has their own little cart, and they essentially deliver their product and their services independent of one another. And that ultimately is a poor experience, but it also impacts safety. The other aspect is fatigue and how in other safety critical industries they take fatigue much more seriously than we do in healthcare. And this is a real pet peeve of mine, is that for whatever reason we feel it's very necessary that residency requires long shifts, 24-hour shifts, maybe as long as 28-hour shifts in some jurisdictions. And the other thing that I don't like about this aspect is we're supposed to be evidence-based in healthcare, and we certainly know what the effects of fatigue are on human performance. Um, it is also a bit of a badge of honor, and all you need to do is go on social media and see, these humble brags of people doing very long shifts, and people talking about it, people again humble bragging about it, and it's even gone on to TikTok and all these other social media platforms about how boastful people are about how hardworking they are. And in the end, this would never be allowed in other safety critical industries such as aviation or the nuclear power plant. And in fact, and you probably experienced this before, is that there are rules around how long the aviation crew can be active. And you may have experienced this, that you're waiting for a flight and all of a sudden there's an extended delay because the crew has timed out and they need to be replaced because they cannot complete the flight under the number of hours that they're allowed to. And also in the case of the nuclear industry, there are situations where you cannot do safety critical tasks between the hours of 2 a.m. and 6 a.m. because of your circadian rhythm is such that you are your performance is poor during those hours. There's also a maximum number of hours that you can be in the power plant. Again, trying to protect yourself and the power plant from fatigue. And so we did this study with CSA on contrasting of safety management in critical industries, safety critical industries versus healthcare. And this is what we learned. So aviation has these quality management systems, a very formal quality management system that they're certified, and they cover things like the design of the airport, the design of the aircraft, and individual components. So that's the notion of a quality management system. But it extends into aviation operations. So they're highly regulated in terms of safety management of the aerodromes, of the pilots are being regulated, air traffic controllers, and even the people who perform maintenance are all under a safety management system. So the extension of the quality management for the design and manufacturing extends right into operations into something called the safety management system. And what we found is that this is also done in the nuclear industry. So there is a quality management system for the design and manufacturing of the nuclear power plant and the equipment design in the nuclear industry. And on the operational side, yes, there's something called the integrated management system that regulates and ensures the quality and safety of the power plant itself, the operators, and yes, the maintenance of the nuclear power plant. But when we get down to healthcare, well, surprise, perhaps not, but we do have a lot of regulation on the design of manufacturing of things like blood products, what's used in transplantation, medical laboratories, the pharma industry, and medical devices. And there are quality management systems that are well established in healthcare. However, when we go on to the operational side, there's no such thing as formal quality management systems. It's entirely ad hoc and self-regulated. So hospitals have their own operations, they have their own quality programs, all independent of one another. Same with home and community care. Physicians are self-regulated. There is no oversight of physicians other than themselves. Same thing with nurses and allied health, unlike any other safety critical industry. So when we look at this across the spectrum, aviation and nuclear and healthcare, you can see one of the major differences in how healthcare operates is the self-regulation of operations. So physicians dictate how physicians operate, nurses dictate how nurses operate, allied health the same. Hospitals are autonomous, home and community care are autonomous. They are mostly self-regulated. It is a myth to think that there are government agencies that are dictating on how hospitals and home and community care physicians, all the clinical people, how they should be delivering care. Not even Health Canada. Health Canada is, in fact, on the other aspect of the management system, on the quality management system. They do regulate blood products, med labs, pharmaceuticals, and medical devices. They do not regulate on the operational side. So this is a stark contrast, and it is to me the main reason why there is a gap on safety is how highly regulated aviation and nuclear is, and healthcare we are self-regulated for the most part on the operational side. So when we go into looking at design of facilities, given this context, the one thing that we learn about human factors is it is foundational to human factors is that people are fallible, humans are fallible, we will make errors. And it's the job of human factors to minimize those errors. And when an error does occur, it's to minimize the harm that will be done. And human factors is not only a methodology to find causes for problems, but it is there to solve them too. And one thing that we always ask ourselves is why are there so many failed products in healthcare? And to me, it's always comes down to there tends to be a lack of empathy in the design of health products, and largely has to do with um, why people think that healthcare professionals are highly educated and sophisticated and they don't need all the hand-holding. But there is this concept of designing the right thing and designing it right. And you have to look at products against this double diamond. One of the things that I think are at the core of this is that, why do doctors hate their computers? And at the core of it is that there's a lot of health products out there that seem like they were designed like 30 years ago, like you're stepping back in time. Even the most sophisticated electronic health records, this is Epic, um, it seems incredibly cluttered, and there's, across the top there is multiple layers of navigation. There's navigation down the left side as well. And again, very difficult to use and requires lots of training to get to be proficient in the use of a lot of electronic health records. So much so is that what's happened, in recent years is that the physician has abandoned people. Like you look at this fellow on the right, that is a scribe, and it's pretty damning to see that these some of these products are so difficult to use, are so obtrusive that the physician has given up on it and has hired someone to deal with um, the data entry into and the clinical note taking that's in the EHR. And I mean, it's been notable that the use of scribes has, reduces EHR use and restores joy of practice. And, you see here, look how happy everybody is in terms of the use of scribes. And I think the most interesting development in scribes is now there are AI scribes that are incredibly popular, and not just AI scribes for the physician, but patients are now bringing tools to their clinical encounter, their doctor visits, and using patient-oriented scribes. So, although they're listening intently, they're probably missing a lot of details that an AI application will not miss, and also do a lot of translating for them. Not only on the medical nomenclature, but especially if English is your second language, it's very effective in helping you understand what you just went through with a clinical encounter. The design gap is pretty significant still in healthcare. Like I argue that bad design is pretty pervasive in healthcare. A lot of products aren't formally designed, and this was a an article in the New York Times a number of years ago by a resident, and he lamented that that there should be better design, and we should be more evidence-based in the design of our facilities and so on. But I would argue is that it wasn't really a question of bad design, is that they were never designed in the first place. And again, there's a lack of regulation in the operational side of healthcare. So there's no necessarily rules on how to design a form, design a clinic, design a facility, other than what's required by law, right? And so, why are there so many failed products in healthcare? There's another aspect of healthcare that it doesn't is not conducive to good design, is that healthcare is becoming increasingly opaque. And there was a time where companies such as Johnson and Johnson were allowed into clinical environments, and companies and designers were working side by side. But now it's become much more difficult for companies, designers to work in this context because of privacy rules. At the beginning of my career, for better or worse, it was quite easy to bring in a company engineer to work in the operating room alongside physicians and clinical staff. But now, because of the rules, it's not impossible. It's allowed, but it just requires a lot more effort. And unfortunately, we are doing without that direct involvement and direct oversight of how people are actually working. And this is where my team is actually quite valuable, the human factors team, is being hospital employees, they can look at all the interactions that happen within the healthcare setting and be able to clearly understand workflows and the complexity of healthcare, where companies are only imagining what the interactions are like. So this is, I think, very important for anybody who's thinking about designing new systems is that they have to have access to systems that allow them to understand and be able to interact with staff on a direct basis and doing direct observations. So again, the other reason why we have failed products is that we also do not think about the design from a team, an organization, and a policy perspective. Sometimes we only look at it from the physical or psychological level. And the contemporary aspect of this is to start viewing everything you do as a service and start challenging why we do things. And we have this sort of experience in a physical encounter in healthcare, and we subject patients to these types of artifacts and forms, and we ask them to come to the clinic at 8:25 a.m., very specific on a Tuesday, yet this is the experience they have. They're sitting there waiting. On the digital side, we are trying to make healthcare a lot more virtual, and co-designing the experience of digital health with the patient. Everything from their integrated care journey for transplant into co-designing and a service for the prevention of chronic pain in children, all these things. And we also had done work in Ebola preparedness. Is how do we prep our staff using all this uh, personal protective equipment. We did work on the Syrian displacement back in 2018. When we were going to be accepting 25,000 Syrian refugees, we had to plan at the Pearson Airport how we were going to develop the workflows. We spent 3 weeks working with colleagues, and we did dry runs and designing the layout of these areas in a user-centered design fashion, and preparing the equipment, all the flows, the signage, everything. And this was in the end a success, and able to get ultimately 35,000 Syrian refugees through that process in a very short period of time. The healthcare manufacturers group was also quite critical during the pandemic. They were involved in patient flow during the pandemic, especially when areas of the hospital were closed down. Lots of PPE evaluation, N95 reprocessing. They did ventilator evaluations, where, if you recall, there was a concern at the beginning of the pandemic that we weren't going to have enough ventilators. So, studied a lot on what was available to us and what alternatives there were, including splitting the outputs of a ventilator to service two patients. And we used our usability labs. These are our labs that we can simulate parts of the hospital, everything from critical care to wards, and also products such as this device, which was designed and tested at our facility here in Toronto. This is the Solus device. Now, one of the very exciting things is the use of artificial intelligence. It's creating a lot of buzz. Canada was critical. This fellow on the right, Geoffrey Hinton, won the Nobel Prize in physics for his work on artificial intelligence, and particularly the use of artificial neural networks in simulating how we think, and creating this notion of deep learning. And again, the idea that the strength of these connections between neurons could be simulated mathematically. And that was the beginning. And he was doing this back in the 80s, when people really didn't understand it, and it was technically difficult to do. But recreating what the neurons do and the strengths between these neurons, and simulating it in a computer system.
Hey, are you there?
And I want to show you an example here of an advanced AI system. and think about what the implications of this, if you could actually start communicating with your medical devices. So this is an example of this is a version of ChatGPT that has vision, and you'll hear me conversing with it while trying to program this infusion pump. And I think this is kind of like the future of where we're headed with user interface design and the implications on this on safety.
Hey, are you there?
Hey Joe, I'm here. What's up?
Can you see?
Yeah, I can see it. That looks like an infusion pump. Are you having trouble with it?
No, not really. I've never used this before, but what I'd like to do is a heuristic evaluation. I want you to walk me through a common task and make note of all the heuristic violations that we come across while using the pump. Does that sound okay?
Sure, we can do that. What's the specific task you'd like to evaluate? For
Well,
example,
what would make sense?
programming a basic infusion rate is a common task. It involves turning the pump on, setting the rate, and starting the infusion. Does that sound good?
Sure. And let's just use the Nielsen heuristics to keep it simple, okay?
Perfect. We'll look at things like visibility of system status, error prevention, and user control. Let's start by turning the pump on. Are there any issues with the power button or startup?
Okay, there's a button here, system on. I'm going to assume that's it.
Yes, that's likely the power button. Go ahead and press it. We'll check how the pump displays its status as it starts up.
Oh, what do you think? It looks like it's on now.
Great, the system status is visible. Now it's asking if it's a new patient. This is a good example of a clear prompt. Let's note the heuristics. It's supporting user control and freedom here.
What should I do
So
next?
let's proceed by selecting yes to confirm a new patient. Are the buttons clearly labeled and easy to press?
I'm pressing yes, but nothing's happening. Can you see?
I see, there's no immediate feedback on the screen. That could be a visibility issue. Let's wait a second. Sometimes there's a delay.
Nope. I don't think this is a touchscreen.
Got it. So if it's not a touchscreen, you'll likely need to use a physical button. Are there arrow keys or a select button near the screen?
Oh, there it is. I'm going to use that.
Great.
Okay.
Now,
So it's these buttons along the side here.
exactly. Each button likely corresponds to a menu option. Let's press the one next to select channel to proceed.
That's silence.
Good catch. Inconsistent labels can cause confusion. It's a minor usability issue. Let's move on to setting the infusion rate.
No, I still haven't selected the channel. Here, it says here A. I'm going to select that. But I'm getting an audible error tone.
An error tone suggests something's not set correctly. Let's check the screen for any error messages or alerts.
No, so my instruction is select channel, and it says A here, and I would like to select channel A. And when I select it, nothing happens.
It might be expecting additional setup steps first. Let's check if any other prompts or indicators are flashing.
Oh, there's a channel select over here. Maybe that's it.
That makes sense. Let's try pressing that to see if it allows you to confirm channel A.
It worked.
Awesome. Now that the channel is selected, let's proceed to set the infusion.
So that gives you an idea of how sophisticated AI has become, especially when it has audio, video, and again, I did not train that model to understand infusion, but the video goes on for another 10 minutes, and I can share the entire video with you if you'd like. But it walked me through the entire process of setting up that infusion pump. The other safety aspect is getting patients more involved in their own care. And it's this idea of digital therapeutics, the idea of digitally mediated models of care, better health outcomes, enablement of patients, better experiences, more timely care, appropriate care, and elimination of low value care. And, we're trying to make sure that the quality specialist care is more accessible because right now it's quite scarce. And is it possible for software and AI to be able to do some of the tasks that we're doing now? The other thing that we realized during the pandemic is this virtual care was not going to save us, is that we learned that capacity is actually not increased, it's simply accessed over a distance. So, you take all these specialized clinics at our cancer center, at our cardiac center, at our diabetes center, at the hospital for sick children, and could we encapsulate what physicians and nurses know about the care of chronic illnesses and create software that does this. So, our center here, alongside the Human Factors Group, has researchers and designers and engineers who are working on this and very concerned about delivering care into the new spaces, the home, the pharmacy, school and work, and, Canada's challenging geography in remote communities where it's very difficult to deliver care. And some of the applications that we've developed range from prostate cancer to diabetes management. I'm going to talk a little bit about Medley, which is for heart failure. It gathers data from the patient on their blood pressure, their weight, and their symptoms. And this is all goes into an algorithm that predicts the decompensation. So if they are starting to decompensate and there's noticeable edema or other factors that seem to be leading to potentially a hospitalization, the algorithm immediately contacts the clinic, also the patient, and asks them to change their diuretic medication as needed. And as a result, is that because of the intelligence of the system, a single provider can support as many as 300 patients. And the Human Factors Group was really critical in the design of these products. As I mentioned, they designed many products, but they also used the service design aspect of understanding how our heart failure clinic was operating and created these huge blueprints of understanding how the workflow through the clinic and what the experience was going to be for the patient and the provider. And they prototyped the app and the peripheral devices packaging. So all these things they needed to design, and even things as granular as the forms and the scripts of what was this, like what was the provider telling the patient about Medley as an encounter, right? And lots of intangible interactions. We went through great deal of time prototyping not just the application of Medley, but also the service and how that workflow. And over the years, Medley has been now used over the last 5 or 6 years, and it's been a success from a cardiologist perspective as well as the patient perspective. Let me just jump ahead. And there's lots of more AI enhanced aspects of the application that it is not just taking data from the patient, but it's also going in and looking at EHR data to improve the performance of the algorithm. And the care model is evolving too, in that, again, that single point of contact, that Medley coordinator, which is typically a nurse, and now has access to other allied health care to facilitate the care of the patient. So Medley's impact showed that we could reduce hospitalizations by half, we can improve quality of life, improve self-care, improve prognostic markers such as BNP. And also, what we're very proud of is that you can see here on the dark blue line, those are people 70 years of age and older who are still engaged with Medley after a year. And so, again, we probably have to do more work with the younger patients than we do with the older patients. So the myth that older patients can't handle this stuff is, in fact, a myth. And not that Medley is perfect, we still have work to do, but for older adults can engage. So as many as 80% of people are still engaged 1 year after the use of Medley. And also, we take quite a bit of pride that it's equitable access. So this is not just for people who are in the higher demographic in terms of on the material side. So this Ontario Marginalization Index for 1,100 of our patients showed that, in fact, the patients who were most marginalized were at times more engaged and more represented than patients in the higher marginalization parts of the index. And we've studied Medley now over a decade, and it improves outcomes, it improves clinician experience, patient experience, and the care cost provided. But one of the things that we're really looking at is sort of what would it look like if there were no apps? And so one of my students actually took the time at looking at Medley and putting it on an Amazon Alexa, which I think went some part of the way, but it's still some pretty advanced technology. But what if, the lowest common denominator was in fact just a telephone call? And I'm just going to show you an example of an encounter with an AI voice agent and a patient.
Hello, this is Dr. Ross speaking. Thanks for checking in with Medley at Toronto General Hospital. Just so you know, I'm an automated agent, not a real person. If you are uncomfortable with this, you can just hang up. Otherwise, shall we get started?
Sure, thank you.
Great. Have you taken your blood pressure, heart rate, and weight just now?
Yeah, my weight is 188, but I'm not sure about my blood pressure. I have my monitor here, but I don't know which number is which. There's 3 numbers on my monitor.
No worries, I can help with that. Your blood pressure monitor should show 2 main numbers, one on top and one below it. The top number is called the systolic pressure, and the bottom number is the diastolic pressure. The third number is usually your heart rate. Could you please read out those numbers?
Okay, yeah, so the top number is 145. The bottom number is 95. And it says here my pulse is 82.
Thank you for sharing those numbers. Let's compare them to your baseline. 1, blood pressure. Your baseline is 140 over 90. Today, it's 145 over 95. That's a bit higher than usual. 2, heart rate. Your pulse is 82, which is within a normal range. 3, weight. Your baseline weight is 185 pounds, and today it's 188 pounds. That's a slight increase. Now let's talk about how you're feeling. Have you been experiencing any symptoms like feeling faint, breathing issues, chest pain, fatigue, shortness of breath, or swelling?
Yeah, the reason I'm calling is that I've noticed that my ankles have been swelling quite a bit over the last couple of days. It's actually quite uncomfortable.
I'm sorry to hear that. Swelling in the ankles can be uncomfortable. Can you tell me more about the swelling? Is it getting worse? Is it happening at certain times of the day?
I first noticed it about a week ago, and it's gotten worse over time. And the last 2 days, it's been really bad. And yes, it seems worse in the evening.
Thank you for sharing that. It sounds like the swelling is getting more noticeable, especially in the evenings. Have you noticed any other symptoms like feeling your heart racing, dizziness, or needing more pillows to sleep comfortably at night?
No, otherwise I feel okay.
Thank you for letting me know. Based on what you've shared, it seems like the swelling is something we should keep an eye on. I recommend that you expect a follow-up from the clinic to discuss your symptoms and possibly adjust your medications. If anything changes or if you start feeling worse, please don't hesitate to reach out again or seek medical attention. Is there anything else you'd like to discuss or add?
No, I'm just, well, a couple things. I'm a bit worried that this is going to get worse. And the last time it happened, I was hospitalized. So I'm a bit concerned about that. The other thing is my mother-in-law is here with me, and she would like to hear what you've just told me. She only speaks Mandarin. Could you please repeat in Mandarin?
I understand your concerns. It's important to monitor your symptoms closely. If you notice any worsening, please seek medical attention immediately. Now, I'll repeat what I said in Mandarin for your mother-in-law. 根据您所描述的情况，脚踝的重伤需要我们密切关注。我建议您等待诊所的随访，以讨论您的症状，并可能调整您的药物。如果情况有任何变化，或者您感觉更糟，请不要犹豫，立即寻求医疗帮助。Is there anything else you'd like to discuss or clarify?
No, thanks very much.
So I'd like to stop there, but if you think about the multilingual support, the fact that this is available 24/7, the fact that there's probably about 1 billion people in the world who have little or no digital literacy or literacy otherwise. And now systems like this are potentially accessible to them. So I think it's a very exciting time that, as sophisticated as AI is, it's bringing down the access to the lowest common denominator in terms of the ability to use conversation as the main aspect. So we're going to a world that is perhaps appless, and that we're mostly using conversation in order to communicate and get information. So I'd like to stop there and take questions. Thank you very much.
Awesome. If you have questions for Joseph, feel free to pop them in the chat now. I saw some reactions as soon as the Mandarin started popping on. People were shocked as well as myself, that unseen before. So it's awesome. It's great. Progressive technology that we're heading into. But yeah, if you have any questions for Joseph, we have the last 9 minutes here to answer. In the meantime, I can share some of our upcoming events that we have going on while you're typing. So on November 4th, we have a webinar on the art of well-being, connection through creativity. And November 5th, we have a webinar on adapting leadership styles for team success. November 15th, we have the Happy Brain, and that all talks about mental hygiene. And then November 20th, we have EMDR, and that's a part 2 to a first parter, and that'll be November 20th. So lots of good things in store. So check out our upcoming events page. I do see a question that has come in. So Nicole asks, what are the main barriers and facilitators of the adoption of such tech in healthcare, especially different healthcare settings such as long-term care?
Yeah. Well, thank you, Nicole. It's a great question, and I mean, it does worry me that healthcare is probably going to be one of the last of the sectors to start adopting some of these advanced technologies, even though they seemed pretty innocuous. And again, they're lowering barriers to patients, especially in terms of access and language, etc. And so there are, depending on where you are, there are programs such as, like, the one that I would look into is Can Health. And Can Health is trying to facilitate the ability for companies to do work in the health sector when there is not a lot of funding. And also, I also encourage you to embrace the academia, where a lot of this work is happening now and requires a lot of time and effort of evidence and getting people to come in to co-design a lot of this type of technology. And but healthcare, again, especially in Canada, with the limitations of how we're organized, and secondly, the funding sources of healthcare, which does not allow for a lot of new innovation. But there are programs like Can Health, and as well as academic organizations, colleges and university, which are, really looking for opportunities to engage with long-term care facilities and hospitals in order to design the next generation products for healthcare.
100%. I see Bonita has asked, is Medly an app that anyone can download, or do you have to be referred by a doctor for more isolated locations?
Yeah, thanks, Bonita. I mean, it's, in fact, there are there are patients now in Northern Ontario in very remote communities that are being followed on Medly, but it is a regulated application. It's considered software as a medical device class 2, and it's coupled with a clinic, which so it is something that is prescribed. And I guess the good news is that Medly has recently been licensed to a company, and it should be hopefully more accessible to heart failure patients in the future. But yes, it is something because of the titration of medications. It has to be used in that context, right? So it's not entirely a self-care application, although patients do most of the work themselves other than the titration of medications.
I don't see any other questions coming in, but I do see a comment from Robin. He said this was so interesting, as sure most of us are thinking the same. He said the safety component was not shocking, sadly. Um,
Yeah,
do you
and
have any?
all I would say, Robin, is that I mean, um, we should be emulating other safety critical industries. This is not something that's a quick fix because it's foundational. Our governance is such that the lack of structure and the use, self-regulation is often viewed as a good thing, but the downside of it is how inconsistently we apply and how we execute on care. Again, unlike what a pilot goes through or a nuclear station operator, they are in such a regulated framework that safety is regulated from top to bottom.
I see someone's asking, is there an equivalent to Medley in BC? I don't know if you could speak on
Yeah,
that.
so there is like remote patient monitoring solutions that you probably have heard of, but and I would love to see Medley in BC, and it may be in the coming year. But just I mean, I'm happy to if you want to reach out, I can put you into contact with people if there's interest in Medley in BC. It's mostly now in Ontario, and there are about 5 centers in Ontario that use it. So.
I see Nicole asks, you've really highlighted the pros with such tech. What are some possible issues?
Yeah, I mean, the biggest criticism that we've always had over the years, especially anything that is on a smartphone or an iPad or even on a computer, is that, Joe, you're building technologies for people who already have, access to technology and the worried well, and that's why, in fact, I'm very excited about AI. AI is very sophisticated technology, but it can lower the barriers to access. Now, the concern about AI, which I think is going to be addressed, is its biases, it's its hallucinations. Sometimes it gives you the wrong answer. But I think we are already making a huge, like I have to update this presentation almost every time I give it because how quickly AI is changing and quite frankly improving. And so the quality of the answers are improving, and certainly they are now on par with a lot of medical professionals.
100%. I don't see any other questions coming in, but it was a very informative hour, and I know I got a lot out of it. I'm getting the same likeness out of everyone. So thank you so much, Joseph, for joining us for the session today. Like we said, we'll be sending a follow-up email. So if you wanted to send me the information for Medley, we can include that in the follow-up email,
Yeah.
Joe, and send it out to anybody who's interested. Lots of thank yous and
Oh,
in the chat
yeah, just
for
so explain hallucinations. So Robin, just so you know, what I mean by hallucinations is when AI makes up answers. And
yeah.
unfortunately, that still does occur. It's very convincing in its answers, but if you take a deep dive into it, it's made up the answer, and so that is still a risk about AI. But as I've said, it's improving all the time, and it occurs less and less. Thanks,
Yeah.
Robin. Thanks, everybody. It was a
Yeah.
pleasure.
Thank you.